Hey, everybody, welcome to this episode of Compassion and Courage Conversations in Healthcare. I'm your host, Marcus Engel, and this is the podcast where we teach compassionate communication, provide perspective, and inspire resilience. And I am so excited today to bring to you I can't say an old friend, a friend that I've known for several years, Ryan Sheridan. Thank you so much for being with me, Ryan.
Hey, Marcus. Yeah, it's my pleasure. Thank you for inviting me.
Sure. And I guess we ought to say why you're here, because you are a PA and a cardiothoracic surgeon. Yes.
Yeah. So I work as a physician assistant at Long Island Jewish Medical Center in New York. We specifically practice thoracic surgery. So anything in the chest, basically minus the heart. We have some cardiac specialists that are up the road from us that we work in conjunction with, but it's been great.
Gotcha. And we first met, were you even in school when we first met?
I think our very first meeting, I was just about to go to college. So, yeah, I think my dad had introduced us late high school after having read I'm Here of yours, probably in my mid-high school year. So I think it was sophomore year, and then probably around senior year we met for the first time.
Nice. I remember it well, and I remember your dad well from NYU Winthrop Hospital in New York, and you practice in New York.
I do.
Correct?
Yes. I'm over in Queens now, so it's like the new Hyde Park area. We have a huge hospital and a very busy service.
Very good. And how long now since you've been a surgeon?
The distinction I'll make is just between surgeon and PA. So I never went to medical school, just physician assistant schooling for a number of years. So I went to my graduate program between 2020 and 2022. And then upon graduation from that, I did 1 year of specialized cardiothoracic fellowship. And then since then, so last April, I've been practicing full-time as a thoracic PA.
When you were first going to school, did you foresee yourself in the OR?
Honestly, no. When I first started the entire trajectory, let's say, of thinking I was going to go into medicine, I was pretty gung-ho on being in emergency medicine. It was just kind of my roots from being around Dad at the hospital, having opportunities to work in and around the the emergency room. And through some of the people that I met over my early years, specifically PAs, I had a lot of exposure to what I thought was an incredible career path. So that started me tumbling down into wanting to be a PA. Finally got everything I needed to go to a PA program. And then once you're within the program, you end up rotating through the variety of specialties. And when I finally had the chance to go to the place that I thought I would spend my career working in, which was the emergency room, I came to realize I didn't like it that much. You know, there were qualities about the surgical side that I enjoyed and had seen on previous rotations and then later rotations that I just felt stuck better with me as a person, as a clinician, whatever you might think. So here I am now, nowhere near my initial goal, but I really couldn't be happier with how it turned out.
Well, good. I'm happy for your journey, and I'm happy that there are patients up in New York that are getting to reap the benefits of your skilled hands in the OR.
Yeah, no, it really has been an incredible experience in that, being a PA specifically, which I like to advocate for, it's so flexible, right? So you have these very well-trained advanced care providers that can tackle any number of issues, any assortment of problems, work side by side with the other clinicians, your MDs, your NPs, your RNs, anyone on the overall staff. But you could be delivering it in any sort of environment, right? You could be in a dermatology office, you could be in the emergency room, you could be in the OR. And then after a certain time, you might say, maybe I want to try something else. And then you go over from the OR to the derm office or from the derm office to the OR, right? That's one of the beautiful aspects of what we do in our jobs and our roles.
Nice. I like that. The idea of flexibility throughout one's career, but you're also being able to bring it back to what we talk about here. You're able to practice compassion in different settings too.
Absolutely.
So with this idea of compassion and talking about this notion of empathy, How do you practice compassion with your patients?
Yeah. So, in my specific line of work, I see patients mostly on the post-operative side of the ball. So what that means is they've already been, screened, processed, so to speak, met with the surgeons, met with the surgical team, went through pre-surgical testing. They have an idea of why they're getting surgery, what's going on. And then boom, the day comes, they come into the hospital, they receive the surgery. Maybe I'm helping deliver it. Maybe I'm playing more of a role in the ICU afterwards. But now, so to speak, the deed is done. The surgery is through with. Whatever happened within it, a good outcome, a bad outcome, it's on maybe my side, my team's side, to help sort through the good and the bad and any problems or complications we might have come up across, and communicate. I think that something I definitely learned from you, and I have continued to learn from other mentors in my life, is that communication is by far and away the most important tool in my skill set, at least in the line of work that I have. So I find that to be compassionate to not only to your patient who has just received the surgery, and then also to the family members that have been anxiously waiting for results or to find out updates about the quality of care that's been provided thus far. You have to find a very strong level and a very tactical level of communication to really get across all of your ideas in a succinct fashion while also not overwhelming them. And that can happen in a variety of ways, right? I could go sit down in the waiting room and speak with a family of 15 people waiting to talk to somebody about anything that just happened over the last 6 hours or so during surgery, and walk them through step by step the surgery, what we did, why we did it, how it went, right? And that could be a half an hour, 45-minute ordeal. Or conversely, I could pick up the phone, call so-and-so's, significant other, wife, family member, you name it, friend, and say, hey, this is Ryan from LIJ. Everything went really well. Patient is available to see you probably in the next hour or so. Any questions? No questions? Great. That's it. That's a 15-second thing. Mm-hmm. But 45 minutes or 15 seconds, I've found that does wonders for people's overall outlook on the care we're delivering. And that is one of the things that I feel is the most important from the perspective of compassion.
So let's take two scenarios, because you mentioned this a little bit, both the good outcomes and the bad outcomes. So
Sure.
Let's take two different scenarios. You've got a routine surgery, everything went perfectly, and your patient has a great prognosis for recovery. Scenario number one, how do you practice compassion with them? And then scenario number two would be, well, we ran into some unforeseen difficulties in the OR. The result is not going to be exactly what we wanted. The prognosis is not as good. How do you communicate the good and communicate the bad with compassion? And if you have examples of this or stories that jogs your memory, certainly those are.
Yeah,
I love the real life hands-on examples of how we do this.
Yeah, absolutely. Well, I don't think it'll come as a surprise to your listeners to hear that scenario one is definitely an easier scenario to walk into, and maybe you're not hyping yourself up in the mirror before going to talk to anybody about how well everything went. But yeah, certainly. So in scenario one, I guess across the board, scenario one and scenario two, what I'll say to begin with is the word that always sticks out in my head when I'm preparing to talk to anyone about anything, whether it's the patient after they've woken up for anesthesia or the family members, I should say, is honesty, right? I think honesty needs to be the platform for which you build any type of relationship, and consequently any type of conversation, especially when there's a level of seriousness that comes with it, right? So whether it's going to the person to say, hey, everything went really well, this is exactly what we foresaw, I want to be honest about what can still happen, right? So it's not necessarily to be, someone to draw on negatives or, a down Debbie. I think it's important to also set expectation. So everything to this point has gone well. there are still things in this critical state, right? Coming off of anesthesia, or maybe they have some other health issues that we have to kind of monitor in the post-operative period. We have to make sure all these other things go right. And that's our job in the ICU, or our job then on the step-down unit, to make sure we're going in that right direction. All right. So this is where we're at. 2 thumbs up. We're all excited that everything went well. Let us continue to do our job, and make sure, nothing else pops up. And if it does, we'll handle it. Right. So that's kind of the build out. We talk about the good. We talk about what could go wrong, just so that everyone's aware of it. So there's no true blindsiding. And then we'll go from there. An example of that happened very recently, where it was exactly as we said, a routine surgery. Everything looked great. And the gentleman, because of the nature of our work, we usually leave chest tubes in place to help post-operative drainage, and then also monitor to see the quality and the health of the lung. If there's an air leak afterwards, sometimes it means there's some damage to the lung. Usually those resolve on their own. But what is sometimes less discussed is the fact that they don't resolve. If in the event that an air leak isn't resolving, if the chest tube is showing us that maybe there's some damage to the lung, that patient might have to go home with a chest tube, which is a very daunting task for a lot of people, myself included. I wouldn't want that dangling around necessarily, A few days after the surgery, it was my opportunity to take care of this patient, and they had a large family at the bedside, maybe 10 people literally in the room at that point. And patient was fine, walking around, talking, totally looked like themselves, but they still have this chest tube. So I get in there, I'm like, hey guys, it's looking at this point like the surgical team is thinking you might have to go home with that chest tube. You would have thought I dropped a bomb on their whole day. No one had ever heard anything about this, like there was any concept it could happen. And I just had to take a step back and say, all right, let's just talk about it. All right. If no one's brought this up to you before, that's fine. Let's just have a conversation. And again, coming from a place of honesty, coming from a place where, no. If no one's taking the time to talk to you, I will. Right. Let's sit down and have a solid progression back and forth, questions and answers, until you guys feel good about the overall care. Right. So again, that's really a far cry from a dramatic scenario, right? This patient's going to do fine. They still had their surgery. We still cut out the cancer. They're still going to be able to go home. It's just with this little hiccup. Had that hiccup been talked about immediately post-operatively, I might not have had 10 people with crazed eyes looking at me, so to speak. And then on the other side of the ball, right, it's the not so great outcomes. And that also runs a wide gamut of reality. Your not so great outcome might be that, hey, we wanted to do one thing. We couldn't quite do it, right? So we do a lot of robotic surgery. We try to go in with minimally invasive ports, a couple of incisions on the chest wall. Let's say we're doing lung surgery. We utilize a robot to access the areas that we need to access. The surgeon will sit at a console managing the robot. My role as a first assist is to stand with the robot and exchange tools. Ultimately, what that does is minimize the amount of tissue that we've disrupted on the chest wall and lead to some quicker recovery times. That's the idea. That's not always the reality, though. Sometimes you attempt to do a procedure like this, and any number of things can limit us from utilizing the robot appropriately. And what you have to do then is convert to what's called a thoracotomy, where you're making a much larger incision on the chest wall and opening it up. So that, that's my real life example of, okay, we tried plan A, couldn't get it done. As discussed preoperatively, we went to plan B. Plan B went fine. We achieved what we wanted to achieve. And we're happy to say that, while the recovery time is a little bit longer, the prognosis is still very good. All right. So that's kind of like a big hiccup in what maybe the family or the patient was thinking they were going to be up against, but at least it went well. In my experience, some of the negative outcomes, or, trying to show compassion when things have gone really downhill, come downstream. Immediately post-op, usually things are decently controlled. It's more like a few days in the ICU, things aren't improving, or maybe different organ systems aren't reacting as well to some of the medications or the overall treatment plan that we've set aside. And then you have to start to get into the weeds. But honestly, again, at that point, it's really just about being honest, sitting down with people, taking the time to really discuss what's going on. And I like the phrase setting expectations just because I think if you sugarcoat everything for too long, people will develop, and or I should say families and patients will develop a wrong sense of what's going on. And you don't want to gatekeep that information as healthcare providers. It's really not fair. We have the ability to not only understand the medicine, but also communicate it. If you have the opportunity to communicate it, you should. So that's kind of the tenet of my approach.
I love that, and I guess I'm thinking of um, even other scenarios where you have, gosh, not a bad outcome, but a fatal outcome. I imagine that you occasionally have some of those, or that you can't deal with, and then you have to deal with the families afterwards to share like really, really bad news.
Yeah.
Honesty has to come first in that discussion because you can't, there is no sugarcoating, as you said.
And I'll share with you this. In my experiences as in a young clinical career, I'm very grateful to have worked with some incredible, truly incredible surgeons that do work like I could have never imagined. And then beyond that, by an extension of them, my fellow ACPs, my fellow PAs, the nurses, our team over there, and then also just in general from what I've seen in New York has been top notch, incredible. Um, when it comes to those moments with families and facing fatalities and the loss of a loved one, the loss of a patient, my experience has been that I've almost been part of those conversations on their side because of the time that we spend with these patients on a day-to-day leading up, let's say. So if they're 10 days or 20 days or 30 days, or really in some extreme circumstances 200 days post-operative, we have spent countless hours reviewing these charts, reviewing these medications, talking about game plans, potentially going back to the operating room for subsequent surgeries, and all the time talking with these family members, talking with the patient perhaps. And when you have a sense of how much we spend time with them, I'm sure you can appreciate that when it comes time to maybe withdraw care, or the patient for whatever reason has passed away, you have been like family to them. And maybe that's a specific experience. I don't want to blanket for everyone, but I know that from the perspective of a surgeon and the perspective of the people that work in the ICU, when you start to pour that amount of time in, inevitably you become attached in some way, shape, or form, and those people leave an imprint on you. So when you go to have that conversation, it's more from a perspective of not shared sorrow, which isn't fair to the family, but in some sense, you're feeling their emotions because you've seen it the whole way through.
Ryan, what a beautiful example of humanity. I think so often America, and probably with some validity to this, is critical of the healthcare ecosystem in America. We know that there's all kinds of problems, et cetera, et cetera. And one of the biggest complaints that people say is, "Oh, I just feel like a number. I was just part of the assembly line in healthcare. They didn't care about me as a person." But what you're talking about is a love, and a valuing of your patients in a way that is deeply human, and that's something I think that um, most of Americans don't get to hear from their providers. And I want to thank you for sharing that.
Yes, of course. Not to put a caveat or an asterisk on it, but I should showcase that I'm still human, right? There are hard
Sure.
days at work. I have colleagues, myself especially, where you might, after those 12 or 14 hours of operating, you don't want to have that last conversation, right? You don't want to go step out in the waiting room and field questions for 30 minutes. And I'm not perfect. There are times where I haven't made those conversations happen. But when I do, I then can't help but think about the times that I haven't, if that makes sense, right?
Mhm,
So it's
mhm.
the times where I get that handshake at the end or that smile and the thank you, the genuine thank you for taking the time to talk to us. That's what drives me to have the next conversation and leads me to regret not having the one that I bypassed uh, you know, previous circumstances. So every time every time I show compassion or feel that, sharing of compassion, I think it only helps snowball into doing it more and more um, as I go forward in my clinical career. And something that I try to help mentor or train into new hires and young PA students that
Mhm.
are looking for that sort of advice.
So speaking of young PAs, new or students, as you also said,
Mhm.
uh, whenever you think of leadership, who taught you leadership?
Oh, I mean, the close to home example that you can definitely appreciate is my
Mm,
father for sure.
sure.
But with saying his name, I should also say my mother too. It was kind of like a, a two wave approach, if you will. I had two fronts of people teaching me leadership. I had leadership in what you might call the quote unquote real world or business world, or where suits and ties are out to play and interviewing and whatnot. That was definitely my father. An exemplary businessman, but administrator, but really just a friend of those that worked for him, worked with him. He was I shouldn't speak in past tense. He can listen to this. He is.
And if he is, hi, Dennis. We hope you don't mind we're talking about you. It's in a good way.
Yeah, well, I told him he should join me on the podcast, and he
Yeah,
was too
yeah.
camera shy, so I took up the mantle. But speaking for him and really at him, he is an exemplary individual that showcases, as we continue to talk about, compassion. He thinks about his coworkers. He thinks about the people that work for him. And then ultimately in the hospital setting, even without being a clinician, he was thinking about the patients. And as a young man, going really as a child to go see him at the hospital, go see dad at the hospital. And then as a young man, volunteering in the hospital that he was working in. And then as a young adult, working in the same hospital as him and bumping shoulders with him, getting lunch with him. I got to see this on literally a day-to-day basis. How he held himself, how he conducted himself, and instilling that sense of leadership in me was very much a process of osmosis, right? Just
Yeah.
right next to him. And
We
then
should all be so lucky to have an example like your father to mentor us up. Now, and you're going to say about your mother too.
absolutely. So on the other side of the ball is the home life, right?
Mhm.
So without mom at home, this whole thing falls apart because trust me, I can say all these nice things about my father, but I could watch him burn water before we actually had a meal at home made by him. So with mom at home, making sure that everything else was running smoothly, ticking along, she taught us a different independent type of leadership where you're strong for yourself and you find your own identity. You continue to maintain the things you have in this life. You don't take anything for granted. Those were the kind of the tenets of how she brought us up, meaning my brother CJ and I. And it was between those two, you know, rock walls of a foundation, mom on one side, dad on the other, that I was really brought up in a surefire environment to feel confident in myself and then also to understand what maybe it might take to be a leader in certain environments.
Nice, nice.
Yeah.
Whenever we were talking earlier about the very human aspect of providing care for patients, uh, the course that I teach to pre-meds at Notre Dame is called Introduction to Personalism in Medicine. And so we're trying to teach these young, hopefully soon to be doctors or soon to be providers, ways to be more present with patients. And I'm wondering if you can uh, give me a story about their first writing assignment at the beginning of the semester is to write a short 2-page reflection on a time that someone was there for you or that you were there for another person, very much basing it off of the I'm here and Jennifer story. And so, does that bring up any stories for you about a time that someone was there for you or a time that you were there for somebody else that it truly communicated compassion?
Yeah. As you started to describe that, I have one that kind of stands out to me. And in fact, it actually kind of covers both sides of that, where I felt like I was playing in a role and being there for someone while they were actually kind of there for me in a sense. And that story comes from pre-PA Ryan, pre-PA school Ryan, um, recently graduated from college Ryan, was working in the emergency department at NYU Winthrop as a ED technician, so kind of like a nursing aide. Not a lot of clinical credentialing. We were taking vital signs and playing a role with maybe some of the physical management of the entire department, but really no role from a clinical analysis perspective. So it was a great way to get experience prior to PA school. Um, my first week on the job in the ED, we had a 21-year-old gentleman die from studying cardiac arrest. And at the time, I was 21. In the ED, the code was run for a little while. Eventually, it was deemed that we couldn't go any further, and we called a time of death. With that, his two parents came into the room just minutes after everything was said and done. He was transported by ambulance. They drove separately. And ultimately, they never even got to say goodbye to their boy. Obviously, a powerful story in its own right. For me, it was very leveling as I was seeing this patient pass at the equivalent age of mine. At the ripe age of 21, you feel invincible, right? You feel like nothing can touch you. I had barely broken a bone my entire life, let alone something like this. And so with the medical team scrambling to either, wrap up what they were doing and eventually have to give some conversation to the parents, it was kind of this intermediary period for the parents who were beginning to mourn, but were still in shock. And there was still a lot of commotion going on. And in that moment, I recognized that I didn't really have a clear-cut role as to what they wanted me to do in this spot. I could potentially go back out to the main flow of the emergency department and maybe ask if there's another job for me to help out with. But probably subconsciously, I wasn't even ready to do that. I was still kind of stuck in that room, so to speak. And so my decision in the moment was to go talk to the parents and lead them to a place that was maybe a little bit more quiet and give them the time to start to process what happened. And what I didn't realize was that they would start talking to me. They would ask me questions, and I didn't really have these answers, right? I'm not clinical. I had no training. But it was through our very topical conversation. And as they started to realize I couldn't answer them clinically, they were sort of just asking me more broad questions about how they should be reacting emotionally and how I was feeling. And we got into this very incredible rhythm for at least what felt like 3 hours, of course, but it was probably like a minute or two where we were just with each other. And I'm not sure if it was my age. I'm not sure if it was just maybe the way I looked. Maybe I looked scrambled and they thought maybe they were helping me out. But either way, the three of us had a moment together where I felt like compassion couldn't even be described. And it was two ways simultaneously. So it was from there that eventually they were able to go back in and see their boy and, go on as they needed to. I went back to my work day and then eventually my work week and then eventually your work month. And that experience starts to fade. But to be honest with you, anytime I reflect on that, it just is a sheer reminder of the power of just either physically being with someone, which is something that you taught me, and also just recognizing that even when you don't have all the answers, it's okay, right? You don't have to answer everything. You don't necessarily have to receive every answer. Just if you're trying and you're being honest, as I've said a few times now on this podcast, I think you'll go a long way in helping people.
Yeah.
So, yeah.
Love that. Thank you for that. That's a really wonderful story, touching story. So let's, in the time we have left here, I'd like to shoot some kind of rando questions by you.
Sure.
So let's go back to pre-college Ryan. Let's go back to like 16-year-old Ryan.
Yeah.
It's Friday night. it's after practice or it's after school, you're hanging out with your friends. What are you guys listening to? Period. What are you listening to? Question mark.
Oh, listening to. Oh,
Yeah.
well,
What's on the radio? What's on the stereo, etc.
16 years old. I think at that point, I already had Spotify. I think Spotify was already around. So that was a blessing because that meant I could just strong arm everyone and just DJ whatever I wanted.
Nice.
And now at that point in time, I'd say it was probably a good, healthy mixture of some rap, believe it or not. I think there was a little bit of, high school rap going on then, and then a lot of rock and roll. Definitely a lot of like classic rock. My mom and dad influenced me pretty strongly with that. So that's probably the base of what we were up to.
Nice. I've never discussed music with your father, but it makes me happy to know, and it doesn't surprise me to know that
he's got a sneaky amount of music knowledge. But my mom was definitely the rock queen. She knew what was going on.
Nice. So one of the last questions I have for you is, we've talked a lot about humanism today. We've talked a lot about personalism and being there for people. So if you had the world's largest billboard on top of the world's tallest mountain, what's the message that you would like to broadcast to humanity?
Oh boy. There's a phrase that has been kicking around in my head for a little while now, and I think it sums up a lot of how I would like people to kind of just act or maybe change their perspective. And I think simply put, I would just write "enjoy it" up there. And the "it" is whatever you want to make it, but remember that there's a way to enjoy the things going on, and maybe it's not that easy to enjoy things, but whatever you can, whatever your "it" is, get out there and just do it. Have that happiness in your life, or have the ability to recognize what could possibly be making you happy and maybe you're overlooking.
Yeah, I always think about that you don't want to be on your deathbed and look back at life and say, gosh, why was I never happy? Why did I never enjoy myself? Like you're just saying. And
absolutely right.
That's a thought that keeps me up at night, is not having that, not being the experiencer of regret that we didn't, as Thoreau says, suck out the marrow of life while we have it.
Right on. You have an opportunity to not only enjoy what's going on in your life, but also maybe make other people around you happier. And I think on a day-to-day basis, if you strive for that, good things will come.
Yeah, good stuff. Well, Ryan Sheridan, thank you so much for being with me today. Is there anything that you'd like to share with the listening audience? Any final thoughts before we wrap up?
Well, enjoy it, I guess.
Enjoy it. Yeah. All right. That'll work.
That's it. It was a pleasure to be on. Thank you, Marcus. Thank you to your whole team, Taylor, everybody. It was really nice to interact with you guys again after many years, and who knows, many years from now, let's do it again, or next year.
Let's do it. Yeah, let's do it next year. I'd love to take you to dinner next time I'm in New York.
Let's do it. That'd be great.
All right. Well, thank you, Ryan, and thank you, listeners, for joining us for this episode of Compassion and Courage, Conversations in Healthcare. Please visit marcusengel.com for your keynote speaking needs, narrative trainings, healthcare consulting and patient experience, and HR. I appreciate all of you, and we'll see you next time on the next episode of Compassion and Courage.